Hello, I'm Michelle Kittleson, a cardiologist, professor of medicine at the Smith Heart Institute at Cedars-Sinai in Los Angeles, California. So, historically, there has been a lack of safe and effective weight loss interventions for patients in general and patients with heart failure in particular. But now we have these novel anti obesity medications that offer significant advances. These include agonists of the glucagon like peptide GLP-1 and glucose dependent insulotropic polypeptide GIP, semaglutide, and tirzepatide. And what we know from these agents is that they demonstrate improved cardiovascular outcomes in individuals with diabetes with and without cardiovascular risk and cardiovascular disease. They also offer a reduction in the incidence of heart failure events, and the benefits have now extended to those patients without pre existing diabetes. So, the emergence of these agents allows us to shift our focus and how to effectively manage obesity for patients with heart failure. There are a number of new recommendations in the ACC Scientific Statement for the Management of Obesity in Individuals with Heart Failure. First of all, it's important to recognize that obesity treatments offer opportunities for improved heart failure symptom burden, functional capacity, quality of life, and reduction in hospitalizations. Secondly, it's important to remember that while BMI is historically the key metric for identifying obesity and is deeply embedded in research and clinical practice, trials, and FDA approval, even though it is inexpensive, easily acquired, readily reproducible, there are significant limitations. First, because it was developed predominantly in white men, it has weaknesses for the identification of excess adiposity as well as health consequences across diverse populations. Second, it does not distinguish adipose tissue from muscle mass or fluid retention. And third, it does not identify the location or metabolic consequences of the adipose tissue. And we know that centrally located adiposity is more strongly associated with metabolic consequences and cardiovascular risk. Thus, if an individual has a BMI under 35, it is useful to perform a direct assessment of adiposity as confirmation of clinical obesity, most readily done with an assessment of waist circumference. Other recommendations from this statement. We have to remember that behavioral changes aimed at intentional weight loss are appropriate to attempt for individuals with obesity because even modest changes in body weight can result in improvements in cardiovascular events, although weight loss can be unsustainable. And while there is insufficient evidence to date to state that semaglutide and tirzepatide reduce heart failure events in individuals with HFpEF and obesity, there are exploratory analyses to indicate favorable changes in biomarkers and imaging parameters to suggest a potential distinct mechanism outside of weight loss alone. So it's so important for clinicians to recognize the challenges and opportunities for implementation. First and foremost, clinicians should be aware that obesity remains a stigmatized condition, and some individuals may experience discomfort with being weighed, abdominally measured, or talking about their weight during a medical visit. So it's important to meet the patient where they are in their weight loss journey. Second, it's important to recognize the approved indications for the currently available anti obesity medications. In the United States, semaglutide and tirzepatide are FDA approved for type 2 diabetes and overweight with either one weight related comorbidity or for semaglutide, cardiovascular disease, and for tirzepatide, obesity with sleep apnea. So there's no distinct FDA approval for heart failure with preserved ejection fraction, though these patients will often meet other of the FDA approval indications. It's also important to note a challenge during early phase gradual dose escalation of semaglutide or tirzepatide, which occurs every 4 weeks. It's reasonable in these individuals with HFpEF to monitor their kidney function, electrolytes with adjustment of diuretics, antihypertensive agents, antihyperglycemic agents, particularly if they have significant gastrointestinal side effects. So there are a number of significant evidence gaps to be addressed. Number one, what intentional weight loss strategy offers the greatest heart failure benefit? We think it's the anti obesity medications, though they have never been pitted head to head with other methods like metabolic bariatric surgery, which is also highly effective, though invasive. Number two, what is the mechanism of benefit of these anti obesity medications in HFpEF? Is it purely weight loss or something else? Three, will the more potent anti obesity medications be associated with greater heart failure benefit? We know that tirzepatide as a dual agonist is more potent for weight loss than semaglutide, a single agonist, and there are other, even triple agonists in the pipeline. It's unclear whether more weight loss will translate to more clinical benefit. And finally, what about patients with HFrEF? Will anti obesity medications be established as safe and effective? When we think about obesity, when we think about all of medicine, it's so important to try to remove ourselves from our silos of specialization and examine the whole patient. And that's no more true than in obesity, which has shared pathophysiological consequences for diabetes, dyslipidemia, cardiac disease, liver disease, kidney disease. When we address obesity, we treat the whole patient. So less silos, more collaboration among specialties, less who owns the incretin-based therapies and more we own the incretin-based therapies, and that reaching out to colleagues in endocrinology, nephrology, hepatology, primary care, internal medicine in order to give the patients what they need best. And that's a plug, really, for cardiometabolic clinics, which could include multidisciplinary specialists and advanced practice providers, including pharmacists, nutritionists, nurse practitioners, to work together in a multi-pronged approach to manage not just obesity, but the associated comorbidities.